All right, well, we'll start with thanks for joining for implementing outpatient antibiotic stewardship. We are going to go over some discussion topics. We'll talk about barriers to antibiotic stewardship, how we can overcome those, some of the costs associated with inappropriate prescribing, and then we'll talk a little bit about SMART goals as well. So the objectives for this series has been to discuss CDC core elements, which was in part one of this series. If you missed part one, it is available on the CAP Center website. I will put that in the chat here in a second at the end of the presentation. Our other is to identify barriers to improve antibiotic utilization, which we'll go over today. And then the third objective is to create SMART goals for antimicrobial stewardship initiatives, which would be the focus of our third session, which will be in August. So our discussion or homework from the first session was, what are 2 or 3 areas where your facility could improve its antimicrobial stewardship efforts? So I'm going to pause right here for the recording. And if anyone wants to come off mute and talk about some areas they think would be good areas for stewardship, I'll open that up. You could think about outpatient, like nursing home, any areas there, any areas in a clinic, um, anything you worked on already. Well, no worries. For no one feeling wanting to share at the moment, I have areas that we could work on. So areas that we can work on to improve stewardship is accurate diagnosis, using diagnostic tests to improve our diagnoses. Avoiding prescriptions for viral infections and watchful waiting are ways we can improve our diagnosis. Appropriate prescribing. We can improve our prescribing by choosing the right antibiotic for our diagnosis, using more narrow spectrum antibiotics, the correct dose and duration based on your indication, and then weight or renal dosing. Patient education is another area to improve stewardship. And you can do that through posters or discussions of antibiotic resistance, knowing that what the signs and symptoms and giving symptomatic relief for viral infections are another way we can educate patients. A fourth area of areas for improvement includes adherence to guidelines. Our guidelines are constantly changing and updating, and it's sometimes hard to stay up to date on those. So providing education on guidelines is an area where we can improve and implementing those into our daily workflows. Collaboration and documentation is another area of expanding our stewardship. Maybe it's phone calls or consulting an ID provider, or making our antimicrobial stewardship team a multidisciplinary team and adding lab into it, or adding infection prevention into our antimicrobial stewardship team. And then education and monitoring are 2 areas of improvement for stewardship as well. And there's a quote from the CDC that says that healthcare providers are the frontline champions of antimicrobial stewardship with the power to significantly impact appropriate antibiotic use and curb the spread of resistance through prescribing practices and patient care efforts. So as healthcare providers, we are really the front line of stewardship. But this is a conversation about barriers. So what do you think that clinicians report is the biggest barrier to improved antibiotic prescribing? Think about this for a second. What's the biggest barrier that a clinician would think? It's actually, they say, the patients. And how can we improve this so that the people that we're supposed to be helping are not our biggest barrier? Well, sometimes it comes down to communication. And the University of Wisconsin created the DART program project, which is Dialogue Around Respiratory Illness and Treatment. And they studied communication and barriers for antimicrobial stewardship to find out why clinicians think that their patients are the biggest barrier. And what they said is that clinicians say that not prescribing an antibiotic takes longer than prescribing an antibiotic. And this is a barrier to stewardship, and one of the reasons why they believe patients are the barriers. And they also looked at what patients think are barriers and what their concerns are. Well, their concerns are is that they took off work, they've traveled in North Dakota, they could have traveled over an hour to a clinic. They paid a copay to be there, and then they're left empty-handed, telling them you'll get better on their own. And these are really concerns for patients. And this is why sometimes they say, I need an antibiotic. So how can we improve on those two barriers? Communication strategies are sometimes really effective. And this is not just for stewardship, this is for a lot of different issues in life. But in stewardship, communication and training our providers may have better results for us. Things to think about when we have patients is that we really should review the physical findings of our exams, such as the lungs are clear. Like people understand, like the lungs are clear, there's nothing in there. So there you don't have pneumonia because the lungs are clear. Or, and then also providing that clear diagnosis saying you have bronchitis or you have an upper respiratory cold, and not saying you have an upper respiratory infection, because infections in the general public equals antibiotics. So in order to help think that I have an infection, I need an antibiotic. That's kind of how we've always kind of been trained and thought throughout life, but really when it's an upper respiratory infection, it's usually a viral infection. And so if we say something like an upper respiratory cold, people are more satisfied with them not needing an antibiotic at that point. So just communication tips like that are sometimes ways we can overcome some of these barriers to stewardship. Also using like a two-part positive negative conversation as well. Negative meaning like an example would be, this is caused by a virus that antibiotics won't treat. And then the positive would say, what we can do to make you feel better is, and shift that narrative away from, or the focus away from antibiotics or why you're not prescribing an antibiotic. Let's talk about what we're doing to make that patient feel better. And then also always have that contingency plan, saying something like, I expect you to feel better in 2 to 3 days. But if you have a high fever or your breathing gets worse, then give us a call and let's have a conversation again and we'll check and see if something has developed since we're having this conversation today. So making sure we're not leaving them empty-handed and that they have a plan of what we're going to do going forward and what they can do at home is really important for stewardship as well. And this sometimes will also help them, if they have a plan, not feel like they need to just go to a different doctor because, oh, that doctor didn't give me an antibiotic, so I'm going to go see a different doctor. Well, they have a plan in place that they told me to take X, Y, and Z or do X, Y, and Z so then I can start feeling better. And also when we talk about communication training, we want to make sure we don't just focus in on our providers, but we need to focus on everybody in our facility that are going to be talking to our patients. That could be from your front desk staff, someone who's scheduling, lab personnel, our nurses. All of those interactions set up expectations for the patient and may steer them to think they're going to get an antibiotic. So making sure we have good conversations with these groups of people as well. One example that I heard is from someone doing some scheduling is when a patient calls in, they say, let's get you in and see if the doctor can give you something for that symptom. Well, now that's setting up an expectation for the patient that they're going to get something. But if we can say something like, let's get you in and see if the doctor can help you figure out what's going on, now the patient's expecting a diagnosis and working with the physician to figure out what's going on with them, but they're not expecting to walk away with some type of prescription in their hand. So just using words and communication is really important, and it's a strategy to overcome some of these stewardship barriers. Also, communication barriers within colleagues. is also important. So to help with some of these is making sure we understand that there are different communication styles, that we create a space for communication. So open sharing, develop a collaborative environment, making sure that we're working on a group when we're thinking of different stewardship projects or ways to improve our antibiotic use. It's really important that we include everyone that may be involved, especially those that are going to be implementing whatever project we have. We want to make sure we work as a team and come to a consensus on what's going to work best for our facility. And then remember that effective communication requires more than just an exchange of information. When it's done right, communication can foster understanding, strengthen relationships, improves your teamwork, and builds trust. So that is communication, I feel like is a big barrier to a lot of issues in life that if we do a great job of it, it helps everything goes a little smoother. But other barriers besides communication when we talk about stewardship are listed on this slide. First, lack of resources is a common barrier. Financial restraints, limited funding for infrastructure or for personnel or diagnostics can sometimes be a challenge. And also shortage of trained infectious disease specialists may be a barrier. Other barriers include limited diagnostic capabilities. Maybe your facility isn't able to get timely and accurate microbiology testing done. Maybe it takes 3 days to get a urine culture back. Or maybe it takes a week to get a urine culture back because you have to send out. So those are some barriers to stewardship. Knowledge and awareness gaps. Sometimes our healthcare providers may not understand what our goals for stewardship are. So, or maybe they haven't had training on resistance or stewardship principles. And that can affect whether they're going to have a behavioral resistance to any stewardship changes that we want to make. Sometimes there's concerns that what if they do not prescribe an antibiotic, maybe they're liable if the patient gets sick or sicker than they are. So really we have to make sure we look at those when we're looking at overcoming strategy barriers. And then also, are there systematic or structural issues that are preventing stewardship? Maybe we don't have a policy that backs our physicians when they're writing for antibiotics. Or when they're not writing for antibiotics, maybe there needs to be some policy behind that. There's also that pressure for prescribers to prescribe, that patient expectations are big, and that's where if we can start with communicating with patients on the front end, that maybe certain indications are actually viral and they don't need antibiotics. So there's a lot of pressures put on our physicians. And then there's also lack of data and some IT support that are also barriers to stewardship as well. So how do we overcome those barriers that we just discussed? Well, some things to consider is really making sure we understand the time pressures that may come along with our stewardship interventions, such as recognizing other priorities and managing high volume patient loads or administrative tasks. And you can look at those, understanding those time pressures, and maybe try to optimize the workflow. Add it, whatever your intervention is, add it into the current workflow and make it so it's seamless, so it doesn't take more time to do that intervention. And that might be done by leveraging technology, using your EHR, maybe having decision support tools, or try to automate some of these disease states so that your physicians can save time when they're not prescribing an antibiotic. Also, you can delegate responsibilities to people other than physicians. Is there someone else on your healthcare team that is a whiz at the documentation part? Maybe you have someone that's really good at IT and can pull reports really easily and can follow data. Maybe they should be tasked with some of the antimicrobial stewardship responsibilities. Think outside the box there. It doesn't always have to be a physician or a pharmacist that's doing the data part of stewardship. And then also, to overcome barriers is looking at and prioritizing high impact interventions. So focus on something that's really more impactful, that you're going to get the biggest bang for your buck, is what I would look at there. How can you help the most patients, the most with the least investment? So those are some strategies to think about when you're looking at stewardship and barriers. So there was a national survey that was conducted that looked at what barriers are in the out that what barriers there are to outpatient antibiotic stewardship and to better understand the attitudes of doctors towards antibiotic resistance, inappropriate antibiotic prescribing, and the need for and perceived impact of stewardship interventions. So this study was done by the Pew Charitable Trust and the American Medical Association. They conducted a national survey of over 1,500 primary care physicians in 2018. So what they looked at is whether or not physicians recognize antibiotic resistance and inappropriate antibiotic prescribing as problems nationally. More than 60% of respondents said that they believed that they prescribed antibiotics more appropriately than their peers. And so this lack of recognition that their own contributions are leading to resistance and inappropriate prescribing is really a barrier to implementing stewardship efforts. So they saw that respondents generally supported the need for antibiotic stewardship in healthcare facilities, and 72% of them believe that these efforts are necessary to effectively address antibiotic resistance, and 91% felt that stewardship is appropriate for office-based practices or outpatient practices. Although this support is promising, 47% of the respondents said that they would need a lot of help implementing these stewardship interventions within their practice. And when asked about specific types of stewardship activities, respondents strongly supported patient education efforts, with 79% believing that stewardship is ineffective without patient education. However, there's not a lot of support for activities, and half of the respondents did say that it would be difficult to track and report antibiotic use in a fair and accurate measure. But when asked who they thought would be the most trusted person to give them antibiotic feedback on their own prescribing, they did say that about 75% ranked their own health system or the State Department of Health as being the most trusted people to provide feedback. So a barrier to stewardship sometimes might be giving our providers the data, showing them what they are currently prescribing and what for might be a really good stewardship intervention. So some other ways we can overcome some of these barriers and help facilitate stewardship is maybe we need to designate a local antimicrobial stewardship champion, someone that facilitates this patient education, pulls in audits and does some feedback, and then really just coordinates everything around antibiotics. Make sure that this person also pulls in flexible and relevant learning strategies. So bring in some education to your providers and to your patients and find different ways of providing that education. Making sure that it's easily accessed and that there's resources, and often we need reminders. Now would be a great time to start thinking about for fall. There's a lot of viral infections that start in the fall and highlight in the winter. And so those might be some reminders of bronchitis, and this is how we treat, or RSV is high right now. And maybe an email reminder or a topic discussion within a provider meeting might be some good ways to do that. Also, make sure the value of these audit and feedback reports are really important. I think we get good results when our providers see actually how much antibiotics they prescribe themselves. And then really making sure we're highlighting awareness of resistance and stewardship. So overcoming some of these barriers. So we talked about 6 different areas that we could focus on for antimicrobial stewardship. So a couple different things we can do to overcome the barriers that go along with them within them. So we talked about diagnostics and diagnostic facilities being a barrier. But could we potentially do more PCR testing within our clinics? Can we bring in the respiratory PCRs so that we can get the quickly know if it's a viral infection. And those would be great to have versus having to send out a sputum, and sputums aren't always the best cultures either. So that might be something to think about, how we can get around some of these barriers of diagnostics facilities and sending our cultures off-site. Data collection. Sometimes that's a barrier, is we don't have the data. Well, then we can work with our IT resources to help build us and in our EMR, so that pulls that information automatically. Sometimes other clinics or healthcare systems already have reports that they're using. So you may want to partner with them and find out how they did it and what they're doing to report. And then that way you're not reinventing the wheel. And sometimes it helps your IT, because then they can find out how they built that report and copy it. Patient expectations is a big barrier, right? To stewardship, everybody thinks they need an antibiotic. So maybe hang some signs and with virus versus bacteria and how to treat each one. When do we need antibiotics? When don't we? Or talk about antibiotic resistance. And then not letting our patients leave empty-handed, like I talked about earlier. Give them symptomatic relief and a plan going forward. Or I know some facilities do like a baggie full of stuff that you would need for colds, so that if the physician recommended that they are diagnosed that they have an upper respiratory cold, maybe they left with Kleenexes and alcohol wipes or something like that, so they don't feel like they're leaving empty-handed. Sometimes that helps with patient satisfaction. But this all comes back down to lack of funding a lot of times. So how we can overcome that is really prioritize which intervention you want to do, create a budget, and look at how much will this actually cost, and who do we have in place already that we could add on and have them help us create this. And then you have to get C-suite involved as well to help promote and help maybe fund some of your interventions. And use resources that are already available to you. Like, do you have people in place? And then there's a couple resources that may be good for the C-suites, is often they like to see the cost. What is this costing us? Or what is this going to cost us? Or how is this going to save money for us? So inappropriate prescribing does lead to higher costs and higher complications for our patients. So this is a visualization from the Pew Charitable Trust that shows that 4 to 70% of children receive antibiotics that are unnecessary depending on the indication. And for adults, it's 7 to 66% depending on the indication. So as we know, bronchitis is one of those never prescribed falls into that never prescribed antibiotics. It's usually like 99% viral. And 70% of children and 66% of adults were given inappropriate antibiotics for that. When we look at influenza, patients are getting antibiotics for influenza, which we know is a viral infection as well. So this all leads to inappropriate treatment and higher costs of health care. So looking at that, you can look at upper respiratory colds, like the common cold, costs up to $19 million a year in treating for children. Sinusitis, we have 7 million in costs for children and 19 million in adults. So high costs here may be some examples of how you can approach your C-suite of how we can prevent or help fund some of your interventions. All right, so if you're taking this course as a series, we know that there's homework after every presentation. And so for this next one, our next round is to build your antimicrobial stewardship intervention. And there will be a worksheet that I will put in the chat at the very end here, and it will also be on the CAP Center's website as well that I would like you to fill out. It's basically a SMART goal worksheet. And if anyone wants to discuss their SMART goal in the next session, I would love it. If you would just shoot me an email, and I would definitely love to discuss your SMART goal with our group. And if you want a reminder of what SMART goals are, they're specific, they're measurable, they're obtainable, they're relevant, and they're timely. So those are kind of those things to think about. So when you're writing a SMART goal, make sure that we have a clear goal in mind so that it's specific. So one example of what is not a specific goal would be saying lower fluoroquinolone use. That's not specific. Lowering fluoroquinolones by 10%, that would be more specific. And you want it to be measurable, right? So a goal can't be specific if you can't measure it. So in this case, we can measure, we can look at what our previous fluoroquinolone prescribing rate was and look to see, did we decrease it by 10%? It also has to be achievable or attainable. Will the strategy work? Can we lower our prescribing by 10%? So don't set something that's not achievable. You don't want to say like, oh, we're going to lower fluoroquinolone use by 99%. Well, that's not achievable. We're going to have something that you think that you can achieve. Make sure that it's relevant to your patients. Will your patients be safer, or will you have better outcomes with this goal? And try to aim to affect a lot of patients or a really big change for a small number of patients. And then it should be time bound. So really like the SMART goal would be more like lower fluoroquinolone use by 10% in the next year. So you want to have a deadline, and sometimes you can work backwards from that deadline when you're setting up an intervention. So an example of a SMART goal would be decrease the number of antibiotic prescriptions written for bronchitis by 25% in 2025. That would be an example of a stewardship SMART goal. Because it is specific, we know the exact amount we want to reduce, which is 25%. It is measurable because we can work with either in our EHR and work with IT to obtain the previous number of prescriptions for previous years versus the current year for bronchitis. It's attainable. It's relevant because by decreasing inappropriate prescribing, we can help our patients by preventing resistance, preventing side effects, and making sure that we're appropriately treating our patients. And then our time frame for this one would be a year. So this is an example of a SMART goal. So as you're working through, you're setting up your SMART goals, make sure you think about these things and make it a really good one. And then also when you're implementing these SMART goals, make sure we want to consider how to establish effective teamwork and communication. How are we going to communicate the SMART goal? Did we work with others to create this? Did we think about their processes and how is it going to be improved? And remember to think about your whole team, your medical assistants, your nurses, your pharmacists, your clinicians, everyone all together, and really to make this a wide management practice. Well, I want to thank you all for listening to the barriers of antibiotic stewardship. And just a reminder, our next meeting will be August 20th from 12 to 12:30.